Hello everyone. As a part of continuous cardiac education, our topic of discussion today is echocardiographic assessment of aortic stenosis, which will be presented by Dr. Pooja Vyas Madam, who is professor in cardiology at UN Mehta Hospital, having more than 10 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Hello everyone, I am Dr. Pooja Vyas, professor in cardiology department, UN Mehta Institute of Cardiology and Research Center. Topic given to me is echocardiographic assessment of aortic stenosis. So let us first go through the stages of valvular aortic stenosis. Stage A includes the patient who are at risk of aortic stenosis with aortic Vmax of less than 2 meter per second. Stage B includes the patients with progressive aortic stenosis, which includes mild and moderate aortic stenosis. Moderate aortic stenosis will say when aortic Vmax is between 2 to 2.9 meter per second and mean gradient across the aortic valve is less than 20 millimeter of mercury. And mild aortic stenosis will say when Vmax is between 3 to 3.9 meter per second and mean gradient across the aortic valve is between 20 to 39 millimeter of mercury. Stage C includes the patient with severe aortic stenosis who are symptomatic. So in C1, who are asymptomatic, in C1 there will be patients with asymptomatic severe aortic stenosis. So severe will say severe aortic stenosis when velocity maximum is more than or equal to 4 meter per second. Mean gradient across the aortic valve is more than or equal to 40 millimeter of mercury, and aortic valve area is less than 1 centimeter square. And very severe aortic stenosis when this mean gradient across the aortic valve is more than 60 millimeter of mercury and Vmax across the aortic valve is more than or equal to 5 meter per second. C2 is asymptomatic severe aortic stenotic patient with LV dysfunction. So here the LV function, LVEF is less than or equal to 50%. Stage D includes the patient with symptomatic severe aortic stenosis. Here D1 are the patients with symptomatic severe high flow, high gradient aortic stenosis where aortic Vmax is more than or equal to 4 meter per second. Mean gradient across the aortic valve is more than or equal to 40 millimeter of mercury and aortic valve area less than or equal to 1 centimeter square. And D2 includes the patient who are symptomatic but with low flow and low gradient. So here the aortic valve area is less than or equal to 1 centimeter square, but the gradient is less and the Vmax is less. So the gradient is less than 40 millimeter of mercury, mean gradient, and Vmax is less than 4 meter per second. D3, in stage D3, it includes the patients with paradoxical low flow severe aortic stenosis. This we will discuss later on. So the goals of echocardiographic evaluation are: first is to establish the diagnosis, second is to assess the severity of aortic stenosis, and third is to assess the LV function along with it. So here comes the role of qualification. Now qualitative 2D echocardiography. So this image shows the normal aortic valve. So normal aortic valve is trileaflet. It has 3 cusps which are thin and delicate. So here we can see that in plex view 2 cusps are visualized. That frame was taken in diastole, and similarly in diastole parasternal short axis view we can see the 3 cusp of the aortic valve. So normal aortic valve, the line of the commissure will form the inverted Mercedes-Benz sign. And by observing opening and closing of the valve in plex view as well as in parasternal short axis view, we can determine whether the aortic valve is stenotic or not. So normal aortic valve area is 3 to 4 centimeter square, and in plex view when the aortic valve leaflets are normal, the separation of the leaflet will be at least more than or equal to 20 millimeter. So it is normal value. Here we can see that the aortic valve is closed in diastolic frame, and in systole, normal aortic valve cusps will be seen as parallel lines will be seen as the lines which are parallel to the aortic wall. This is parasternal short axis view. Parasternal short axis view is the best view to determine the number of the aortic cusps, and also it will give information regarding the presence and absence of commissural fusion. So in the left image we can see bicuspid aortic valve, and on right side we can see 4 cusps, and it is image of quadricuspid aortic valve. So aortic stenosis can be either congenital or be acquired in nature. In congenital aortic stenosis comes bicuspid aortic valve, unicuspid aortic valves, and in acquired aortic stenosis it may be rheumatic or degenerative with calcification of the aortic valve. This is image of bicuspid aortic valve. On right-sided image we can see two cusps of aortic valve in parasternal short axis view, and in left-sided image we can see systolic doming of the aortic valve cusp, which is very particular about the bicuspid aortic valve. So if we see systolic doming, we should always suspect bicuspid aortic valve. This is image of severe aortic stenosis, and we can see in left-sided image we can see calcification of aortic valve, and also we can see distortic aortic valve anatomy in right-sided image. So it is very difficult to identify individual cusps in patients with severe aortic stenosis, and here we will not be able to see cusp as parallel to aortic wall. Rather, the cusp edges will be towards the center of aorta. In severe aortic stenosis, mobility will be restricted, and also there will be calcification. Also, there will be calcification and thickening of aortic cusps. So, question comes in our mind that can we quantify aortic stenosis on 2D echocardiography? The answer is no. If we try to quantify aortic stenosis on qualitative examination, we may overestimate aortic stenosis. It may look severe aortic stenosis to us, but on Doppler examination, it may be actually only mild aortic stenosis. But still, it can give us some important information, like that if we see that even a one aortic cusp is moving normally, then it excludes diagnosis of critical aortic stenosis. Planimetry can be done on transesophageal echocardiography. This image shows aortic valve area of 0.6 centimeter square on T image at 45 degrees, but still it has some disadvantages. First is this aortic orifice is 3-dimensional in nature, so whatever aortic valve area we get by planimetry is not accurate, and second is calcification and thickening of aortic wall as well as aortic valve will produce shadows, so it will be interfering in calculating true aortic valve area. Next comes quantification of aortic stenosis. So quantification starts with determination of maximum velocity across stenotic aortic orifice, and from that data we can calculate mean maximum pressure gradient and mean pressure gradient across aortic valve, and then comes the continuity equation. So accurate assessment of aortic stenosis depends on one's ability to record maximum velocity across the stenotic aortic valve orifice. So that is the reason we should estimate velocity in multiple echo windows. So we should echo windows which should be used for assessment of velocity across the aortic valves and assessment of gradients are apical 5-chamber view, suprasternal and right parasternal views. And we should take care that Doppler beam should be aligned with the direction of the flow of the stenotic jet. If failure to achieve that parallel alignment will lead to underestimation of the velocity as well as gradients. See here on the left-sided image, the left-sided image was taken in a 5-chamber view, and here the maximum velocity we got is 3.9 meter per second. And when we used right parasternal view, and the maximum velocity we got through that window was 4.8 meter per second. So on the left, in the same patient, we could have underestimated the aortic stenosis if we could not have used right parasternal view. Then comes simplified Bernoulli equation. It is used to estimate peak velocity across the aortic valve, and it is non-invasive method, and it correlates very well with invasive data. Formula used to determine maximum gradient across aortic valve are pressure gradient, maximum pressure gradient across the aortic valve equal to 4V square. Here V is maximum velocity across the aortic valve, and the mean gradient is usually obtained by tracing the Doppler beam, which we got while calculating getting Vmax. And mean pressure gradient is usually software generated, and we can even calculate it by using this formula. It is mean pressure gradient is equal to maximum pressure gradient by 1.45 plus 2 millimeter of mercury. This is an image which shows mild aortic stenosis. In left-sided image, parasternal long axis view, we can see some thickened aortic valve, and on right-sided image, which shows the Doppler image, by putting continuous wave Doppler beam across the aortic valve, we got the maximum velocity 2.6 meter per second. So this is mild aortic stenosis. There are some limitation of this pressure gradient calculation. First is this valve gradients are dynamic in nature and they are load dependent. So if there are variation in heart rate, there are variation in blood pressure, the valve gradients will vary with that thing. Second is malalignment will lead to underestimation of the gradient. So any underestimation of aortic velocity will result in greater underestimation of the gradient, because our equation is pressure gradient equal to 4V square. Here velocity is squared. Second, and another thing is that we can confuse with MR jet due to the similarity in location and direction of the MR and aortic stenotic jet. Misidentification can happen. Here is the image which first one is upper one is the image of aortic stenosis gradient, and lower one is the image of mitral regurgitation gradients. Here regurgitation jet. Here the vertical line here represents the end of the diastole. So we should keep in mind that aortic flow starts after the period of isovolumetric contraction, while mitral regurgitation will start in isovolumetric contraction, and the duration of the mitral regurgitation jet will be longer as compared to the aortic stenosis. Also, if there is concomitant aortic regurgitation with aortic stenosis, it can overestimate aortic stenosis in pressure gradient calculation, and similarly if there is associated LV dysfunction, it can underestimate aortic stenosis in presence of LV dysfunction due to reduced gradients. Uh, quantif- Quantitative examination, the last point is continuity equation. We cannot finish our quantitative examination without finishing continuity equation. Without doing continuity equation, we cannot finish quantitative examination. And it is based on the principle of conservation of mass. So it says that stroke volume proximal to aortic valve must equal the stroke volume across the stenotic valve orifice, and as the stroke volume is product of time velocity integral and the cross sectional area, we can arrange the formula like this. So aortic valve area is cross sectional area of LVOT into TVI, means time velocity integral of LVOT upon time velocity integral of aortic stenosis. So how to calculate aortic valve area? For calculation of aortic valve area, we need three information. We need one is we need diameter or the cross sectional area of LVOT, which we can get in parasternal long axis view, and for TV to calculate and to get TV time velocity integral of LVOT, we need to put pulse wave Doppler just proximal to aortic valve, and to calculate TVI across the aortic stenosis, we should put color wave Doppler across the aortic valve. It will give us the time velocity integral of aortic stenosis. So let us go through one example. So here in left image, we can see diameter of LVOT is 2, and so the radius is 1, and the cross sectional area is of LVOT is pi r square, pi 3.14 into 1 square is equal to 3.14 centimeter square. That is cross sectional area of LVOT. Time velocity integral across the LVOT we got by putting pulse wave Doppler just proximal to aortic valve, and the value we got is 11 centimeter. Time velocity integral of aortic stenosis by putting color wave Doppler across aortic valve, value we got is 59 centimeter, and by putting all these three values into formula, aortic valve area was calculated as 0.6 centimeter square. So it was severe aortic stenosis. And there is one simplified version of continuity equation also, where time velocity integral was replaced by maximum velocity. So here instead of taking time velocity integral of LVOT and aortic valve, we just took Vmax across LVOT and across aortic stenosis, because the flow duration across two sides is same, but usually we don't use this method. Correct method to calculate aortic valve area is this one, by using time velocity integral. Continuity equation has certain advantages. It has been validated in multiple studies and multiple clinical settings, and it correlates very well with hemodynamic data by Gorlin's formula. It has advantage over pressure gradient method in certain conditions, like in presence of aortic regurgitation. Pressure gradient method will overestimate aortic stenosis. Here it will not be affected with aortic regurgitation and LV dysfunction. There are certain limitations also. So image quality, annular calcification, when there is non-circular annulus, and if we do not calculate LVOT area correctly, these all factors can lead to errors. And intra and inter-observer variability for calculating ASZ and LVOT velocity is 3 to 4%, while for calculation of LVOT diameter it is very high. it is 5 to 8%. So we should take care while calculating LVOT diameter, because cross sectional area here is pi r square. So whatever error, even if there is small error in this calculation, so it will be compounded in final formula. According to SCC-AHA guidelines, will say aortic stenosis as mild when by continuity equation aortic wall area is between 1.5 to 2 centimeter square and mean gradient across the valve is less than 20 millimeter mercury and velocity is between 2 to 2.9 meter per second. Moderate aortic stenosis when aortic valve area by continuity equation is between 1 to 1.5 centimeter square. Mean pressure gradient is between 20 to 39 millimeter of mercury and when jet velocity is between 3 to 3.9 meter per second. We'll say it as severe aortic stenosis when aortic valve area is less than or equal to 1 centimeter square on continuity equation when mean gradient is more than or equal to 40 millimeter of mercury and when velocity is more than or equal to 4 meter per second. And very severe aortic stenosis when aortic valve area is less than 1 centimeter square but mean gradients are more than or equal to 60 millimeter of mercury and velocity is more than or equal to 5 meter per second. That says that severe AS can be high flow, high gradient severe aortic stenosis. Severe AS can be low flow, low gradient with reduced ejection fraction, or severe AS can be paradoxically low flow severe aortic stenosis. Here comes the role of Dobutamine stress echo in low flow, low gradient with reduced ejection fraction. So, LV dysfunction with severe aortic stenosis has two diagnostic possibilities. One is either it is true anatomical severe aortic stenosis or it is functional aortic stenosis or pseudo severe aortic stenosis, like mild to moderate aortic stenosis with reduced ejection fraction where the valve leaflets are not opening fully due to reduction in stroke volume. Dobutamine stress echo increases stroke volume and it allows in differentiation of these two possibilities, and when leaflets are relatively flexible the valve area will increase in response to increase in stroke volume, and when there is true aortic stenosis the valve area is fixed, so it will not increase with dobutamine infusion. Dose we use in dobutamine stress echo is 5 microgram per kg per minute, and we increase dose by 5 microgram in 5 microgram increments every 5 minutes up to maximum dose up to 30 microgram per kg per minute, or when we reach normal LVOT velocity of 0.8 to 1.2 meter per second, or we reach normal LVOT VTI of 20 to 25 centimeter. True aortic stenosis with dobutamine stress echo there will be increase in peak velocity and there will be increase in VTI of both LVOT as well as aortic valve proportionately. So the ratio of LVOT VTI to aortic valve VTI will remain constant, and the aortic valve area by continuity equation will be less than or equal to 1 centimeter square. While in case of pseudo severe AS, this increase in the stroke volume will lead to the increased excursion of flexible leaflets and will increase aortic valve area. So whenever there is increase in aortic valve area of more than or equal to 1.2 centimeter square with dobutamine stress echo, it is confirmatory of pseudo severe aortic stenosis or functional aortic stenosis. Here increase in the LVOT VTI will be far more than increase in the VTI across the aortic valve. So the ratio of LVOT VTI to aortic valve will increase. This image shows image of Dobutamine stress echo. Here we can see that LVOT VTI, baseline LVOT VTI and aortic valve TVI both are low, and with Dobutamine infusion TVI of LVOT increased, and as well as the TVI of aortic valve also increased. First image on upper image on left side shows severe true aortic stenosis with normal function, and left side lower image shows severe aortic stenosis with low gradients and LV dysfunction. With Dobutamine stress echo, we could differentiate them into two categories. So either it can be true stenosis where TVI of LVOT to aortic valve ratio remain constant, or it can be functional stenotic where the same ratio will increase, and here in our case it increased to 0.3. Contractile reserve is worth mentioning here due to its prognostic significance. Increase in the stroke volume of more than 20% with Dobutamine is considered as contractile reserve, and it is measured as 20% increase in LVOT VTI by pulse wave Doppler. And failure of ventricle to augment with Dobutamine, it indicates poor prognosis post-operatively. So post-operative mortality with AVR is far higher, is around 50% in patients with no contractile reserve. Response to Dobutamine stress echo can be in severe aortic stenosis, aortic valve gradient will increase, stroke volume will increase, but aortic valve area will not increase. In case of functional aortic stenosis, like in pseudo aortic stenosis, aortic valve gradient will increase, stroke volume will increase, and aortic valve area will also increase with increase in stroke volume. And when there is no contractile reserve, there will be no change in aortic valve gradient or in stroke volume or in aortic valve area with Dobutamine infusion, which indicates very poor prognosis. Last comes the paradoxical low flow severe aortic stenosis. We say that it is paradoxical low flow severe aortic stenosis when LV function is normal, when LV function is more than or equal to 50%, aortic valve area is less than or equal to 1 centimeter square, and aortic Vmax and gradients are less. Means Vmax is less than or equal to 4 meter per second, and mean gradient across the aortic valve is less than 40 millimeter of mercury. And to say it as paradoxical low flow severe AS, stroke volume should be stroke volume index should be less than 35 ml per meter square when patient's blood pressure is normal. The mechanism is that concentric LVH will lead to small LV cavity, and due to reduced LV compliance, there will be reduction in flow. So it is paradoxically low flow severe aortic stenosis with preserved ejection fraction. Thank you so much. This is all about echocardiographic assessment of aortic stenosis.